everybody. Welcome back to the Dr. Terri Show. Today, I am in the studio with Dr. Johnny Peet, one of my favorite people to co-teach with. We teach together, clinicians across the country, and he's just a wealth of knowledge. He's a board-certified gynecologist in the Woodlands, Texas. He's the owner of both Woodlands Gynecology and Aesthetics and the Woodlands Medical Aesthetics Institute. Dr. Peet is an innovator in the fields of gynecology and sexual medicine, and really integrative medicine and an integrative approach to medicine. Today, we're going to talk about thyroid. And the first question is, why is a gynecologist talking about thyroid? You're going to figure that out. He's brilliant with thyroid. But if you have suffered from symptoms of low thyroid, like cold hands, cold feet, depression, anxiety, mood swings, fatigue, can't lose weight, constipation, sluggish metabolism, and you've been told your thyroid is normal, this episode is for you. Join us in the conversation. All right, welcome back, Dr. Peet, again. We're going to talk about my second, I don't know. I've got all the hormones are my favorite, especially since it's a tie, especially since I've gone through menopause myself. Estrogen's, it's way up there. We'll talk about estrogen another day. But let's talk about testosterone, because there's so much confusion about testosterone still. Although I think more and more people are coming around to understanding that it's an important hormone for both men and women. But still, so many people are surprised when I talk about testosterone as a female hormone. It's not just a male hormone. But there's so much misinformation about testosterone in men and women. So I kind of want to talk about that. Again, it's so important to talk about lab reference ranges, because there's certain things that are important to have a lab reference range. Potassium, sodium, things like that. But when it comes to hormones, I can't think of a hormone that falls nicely into a reference range, or vitamin D or B12. All of these things, tie in together. So let's just kind of talk about testosterone first in women, and, how many women are not only running around with low thyroid, but also low testosterone, and what that looks like, because so many women think that hormones really aren't a conversation until they start having hot flashes and their menstrual cycles get sluggish. So let's talk about testosterone in women.
Well, I think when we talk about these types of things in medicine, we have to look at how we got here, the history of all of this. Because why is it that I went through 4 years of OB-GYN residency and never prescribed testosterone to a patient?
Or did you ever even learn that women make or need testosterone?
Correct. Never even was a discussion point or a talking point. How do we get here? Well,
why is that?
Back in the 50s when Premarin came out, it took over the world as the new hormone that all women needed. There were books written, huge media campaigns. So estrogen became synonymous with a female hormone, and the books written about saving your vitality. In other words, if you're not taking Premarin, then you're not even going to be a woman anymore. Right? So the science shows that estradiol receptors are in the same exact places in men that they are in women. And I run my men at the same levels of estradiol that I do my women most of the time. And the science would tell you that androgen or testosterone receptors are located in exactly the same tissues in men and women. And the symptoms of low androgens are identical in men and women. And the treatment is the same except for the dose. It's the same hormone. Science tells you that women will make more testosterone in the course of their life than they will make estrogen or progesterone.
So interesting.
However, it's just in the first half.
Yeah.
Okay.
When we're programmed to make babies.
When you're programmed to make babies. So number one, it's almost like the media has taught us that testosterone is a male hormone and estrogen is a female hormone. Nothing could be further from
the media
truth.
Teaches us a lot about medicine, doesn't it?
Goodness, that's so good. Of course, that's where I've learned everything. In addition to that, in the 80s, the Senate in Washington, looked right there in the Constitution where it said, make sure there's no steroids in baseball. You've got to do that. They decided to spend millions of our taxpayer dollars investigating anabolic steroid use in Major League Baseball. And at the culmination of all of that waste of our money, they changed the schedule of testosterone prescriptions to a scheduled medication. Okay.
And now, what does that mean for the average listener?
That means it's kind of like writing a narcotic.
It's hard to get.
It's hard to do. It's hard to keep in your office. You've got a bunch of DEA restrictions, and it's very difficult to prescribe. So none of those Major League Baseball players were using testosterone.
Right.
They were all using anabolic steroids.
Right.
And the world doesn't know the difference between anabolic steroids and what your testicles and ovaries made in your body your whole life.
Right.
It's natural and good for you. Okay? So when people say, oh my gosh, testosterone causes heart attacks and strokes. No. Anabolic steroids cause heart attacks and strokes. Testosterone doesn't cause that. A matter of fact, when you lose your testosterone, you're at more risk for all of these chronic diseases. So we've got the government stepping in, and when you change the schedule of a medication,
you're not going back.
Not only do you affect prescribing negatively, Big Pharma doesn't want to make drugs that are scheduled that people don't want to prescribe because of the headaches to prescribe the medication. So right now, as we stand, there is no Big Pharma FDA approved therapy for testosterone for women. None. Right. So any therapy we do for women has to be quote unquote off label, which is fine with me. Yeah. But that even further, intensifies this media driven bias that testosterone is not for women.
So before we move on, let's talk about that term off label, because I think it's important for people to understand what that means, and that really I think I read a study one time that showed at least 80%, if not more, of prescriptions in the U.S. are written for an off-label use. You say it all the time. For instance, when birth control pills are used for heavy periods, that's an off-label use of the medication, correct? Or I could be saying it wrong.
There may be one or two birth control pills who have petitioned the FDA and gotten an indication to treat that.
Right.
Or acne.
Right.
But in general, they're all indicated for birth control. Some have indications for those, but we use them all for that.
But it costs millions of dollars for that company to put it through FDA to get that indication.
And you may have one antibiotic that is approved to treat sinusitis, but we may use it to treat UTIs. It's not approved to treat UTIs. You're using it in an off-label way.
Right.
We do this all day, every day.
And it's not a bad thing. So that's a myth I want to dispel, even for, anybody that might sit on boards out there. Off-label is a normal part of prescribing, because it's up to the clinician after they assess the patient and understanding what medications will work for certain things to make that prescription. So testosterone is a big one that is used off-label.
Right. And so when we talk about female androgen deficiency syndrome, right, which has been defined now for decades as a constellation, when we say syndrome, we're talking about a constellation of symptoms that are associated with a clinical finding. Right. And in this particular circumstance, it's a constellation of symptoms associated with decreased androgens. Now, I'm not going to draw a line and say the lab has to be below XYZ, but the symptoms are persistent unexplained fatigue, okay, and mood disturbances, whether that be depression, anxiety, irritability, and sexual dysfunction, whether that's decreased libido, dyspareunia, anorgasmia, all of those things. If we have patients in our office in their 30s and beyond who have those three symptoms all together, fatigue, mood problems, and sexual dysfunction, to treat them off-label, we replace testosterone.
Right.
If all of their symptoms go away, that confirms the diagnosis, and we are able to treat as long as we are managing any kind of side effects they might have, keeping them healthy, and we're utilizing what they're deficient in to treat the symptoms. That's off-label treatment. It's perfectly acceptable and clinically prudent.
And in men, even testosterone use is considered off-label if they have a testosterone greater than 300. This is where the bell curve, the labs come into play, to talk about the labs. And men, as you said, have the same symptoms, but I think in women it seems exacerbated. And I don't know if that's because our well of testosterone reserve is just lower than guys. I don't know why that is. Or if we're just more in tune to our bodies and things like that. I'm not sure.
Well, I think men probably, now this is changing here in the last 15, 20 years, but in the past, men really started to see a decline in their testosterone in their 40s and beyond.
Right.
And it's kind of a very slow, insidious decline.
Right.
A few percentage points a year, and then you just kind of adapt and improvise, and you overcome, and you get through it, and you get your new norm, and you fight through it. And that's different from menopause, where your estrogen and progesterone go from here to here.
Yeah, just
that's
like that.
cliff, right?
Right.
This is very insidious. The same thing happens in women. It just happens a decade or so earlier. Women make a lot of androgens from age 15 to 30. After that, it really slows down, and most women will lose the vast majority of their testosterone in their bloodstream about 10 years prior to menopause, right? And that is when the mood problems and the sexual dysfunction and the fatigue sets in. So you're talking about these women in their 30s and early 40s who are getting medicines for poor focus and fatigue. They're getting Adderall. They're getting mood problems, so they're getting Zoloft, and they can't sleep, and they're on Ambien, and it just one thing after another.
Anxiety, so they're on
anxiety, so we don't ever treat what it's from. Right. If it's thyroid, replace the thyroid. If it's testosterone, replace the thyroid and the testosterone. And guess what? You won't need all these other symptomatic medicines for...
we get patients in our offices, both of us, off those medications all the time, right? Just because we're getting, to the root cause of that. So you said something earlier that I think is important. Well, I want to keep talking about testosterone in women and just to kind of educate. And also the other thing that I've seen is it's kind of a weird phenomenon, but women understand this when I say it. Something happens after that second baby. And you've delivered a lot of babies and you probably have seen this too, but I don't know what happens whether you're 25 or 35. Something happens after that second baby where women will complain, I just never bounced back. I didn't have my energy back. I didn't have my sex drive back. I couldn't get my pre-baby body back, and what we're finding is that's testosterone. So are we biologically programmed that two's enough? I don't know. How does that work? And they're like, you don't need any more. But you've explained this so well in the past.
It's really amazing. First, let's talk about menopause because, there wasn't a whole lot of need for hormones for menopause 40 years ago because no one lived long. And that's 50 years ago because people hardly lived that long. I mean, maybe 100 years ago, let's say. But now they're going to spend 30, 40 years in menopause. So we have to learn how to manage these symptoms. That's what's happening kind of the same way, but you have to fast forward it about 15 years. So I want to think kind of a little bit theoretically. When you're a teenager or in your 20s, right? You may have a normal range of testosterone, let's say 50. Let's just throw a number out there. That's great. Well, what is your instinct in life right then? What is your brain telling you that you need to do? And it's instinctive. You don't have to think about it, but your instinct is it's time to have some babies. We need to get our genes out in the world, and we need to get our portion of the gene pool. And I got to get some in there. I mean, that is it's an instinct. Right. So you may have a little lower sex hormone binding globulin, which is a buffer that binds up your testosterone. And when the testosterone is bound to the binding globulin, it can't get into your cells and work. So when you're younger, you may have a little more testosterone. You may have a little more free bioavailable testosterone. And then your brain can better impose its instincts on you to go out and make some babies, right? But then you have a couple of babies and fast forward 10 years and, let's say if you're 20 years old, your testosterone might be 50 and your sex hormone binding globulin may be 20. Both, quote unquote, normal. But fast forward 10 or 15 years and 2 kids, so you're exhausted, you're up all night, they're driving you crazy, the last thing in the world you want to do is have another one right now until I figure out how to survive every day, right? So what is your brain telling you to do at that point? You have a different kind of instinct. Your instinct is maternal, not reproductive. And if your brain wants to impose an instinct on you, your brain can control your hormones. So your brain can maybe raise your binding globulin a little bit to lower your free androgens, and then your testosterone will kind of go down a little bit, especially if you're sleep deprived and all these other things. So what happens is your brain is saying, you know what? Let's not make any more of those. This is overwhelming. Let's just take care of the ones you got. So we're getting rid of this reproductive instinct. We're starting with this maternal instinct, and you may only see your labs change a little bit. In other words, at 35, her testosterone may be 25 or 40 now. Let's say it's 25. It's only gone down 50%. No big deal. But the sex hormone binding globulin might be 80 now. Okay? So you've decreased your androgens by 50% and you increased your binding by 400%.
Right. And the binding is important to understand because it's that free available testosterone, just like free T3. That really is the important
That's
number.
What your cells see.
Yeah.
That's all your body has the opportunity to use is what is free and bioavailable. So when patients come into my office and they tell me I've had my hormones checked and my levels are normal, I believe them, okay? But what the patient's telling me is, I'm not normal.
I don't feel normal.
This is not me. This is not normal. I'm not a person that cries all the time and that can't sleep and that doesn't want to have sex with my husband and that I can't make it through the day because I can't get off the couch. This isn't me. right? But their labs are normal, which we'll talk about in a minute. So what I tell them is, you know what? This is normal, okay? And once you get into your mid-30s and beyond, you feel and function a little bit differently, right? What was supposed to happen back 200 years ago? We were supposed to have a couple of babies, live maybe 10 years longer and die.
Yeah.
Okay, so now we want to live another 50 years and we want to feel good again.
Absolutely. And you said something important about what's happening simultaneously with the male is his drive and instinct to procreate has not slowed down. But yours has. And this is where I see a ton of marital strife, right? Because everybody's tired. And but because she's lost her testosterone, she's lost her desire, her libido, but he hasn't. And here comes trouble, right? And that's what we see quite a bit. So it's an important conversation to have.
And the vast majority of patients that I treat are couples together.
100%.
And it's actually very gratifying to see people be on the same page. You know, it may have been decades since they were on the same page together with their relationship. And
especially if they're in their 50s when they come. I've heard this so many times. It's just like, we're having a honeymoon season that we haven't had. Where I see it so impactful in a crushing way is, you know, the 35-year-old that has had 3 kids, whose husband is, 40 or 38 or whatever, and his testosterone's rocking, and now she's depressed and irritable and anxious, and now she's on an antidepressant, and now she's emotionally labile, and she's not the same woman he married, and she's not the same mom as the first kid, and this is how this story goes, and it leads into all of this relationship strife, which has this whole other effect on the body that we've talked about in other shows.
And those prescriptions actually make those symptoms worse.
Exactly.
It lowers your desire, makes it harder to reach climax. All the things that are sexual side effects of those medicines, it just compounds the problem.
Right. And those are the women that, that when we get that figured out and get that fixed and get them off of some of those medications, that the husbands are like, thank you for giving me my wife back. We hear this all the time.
Hormones matter.
Hormones matter. Before we talk about young people, because I think it's an important conversation to have on why we're seeing so many young people, talk about guys just for a minute, because I still think there's some myths and misconceptions about testosterone in men. Some of the ones in women are, I think we've kind of busted those, and I get this question all the time. Well, is this going to turn me into a man? Am I going to grow a beard? Am I going to, this, that, and the other? And the short answer is no. Can testosterone therapy have some side effects for women? Sure. Are they easily managed? Yes. I haven't ever in thousands and thousands of patients had anybody stop a therapy because of a nuisance side effect. Just some adjustments. So no, women aren't going to turn into a man. They're not going to grow man parts. They're not going to, voice isn't going to go deep. I feel like I'm pretty feminine. I sound pretty feminine. And
once again, this is the confusion between anabolic steroids and testosterone.
Exactly.
They are not related.
Yeah.
They hit some of the same receptors, but man, the side effect profiles are totally different. So it's very hard to look at reference ranges for women. And I think we're kind of heading to lab values, but
let's talk about men for a little bit and some myths in men.
So let's look at a bell curve. We've done this with some other hormones. Let's do it with testosterone. Now, testosterone is a metabolic hormone, which means the more you have, the more effect that you have, right? So, and it's interesting, I wish they would do this for women, but with men, they change the reference range depending on your age, right? So let's look at where most ranges are. Different labs have their own, but about 300 is usually sitting around the 2.5th percentile. But over here, you're going to see all kinds of different things. If you're talking about young men and they're under 40, it may be 1,100, and then the reference range may change whenever they're a little older, maybe to 900. And then if you're over 70, sometimes it goes down to 800. But in a nutshell, I kind of ask my patients, do you want to optimize your hormones for a 40-year-old or a 70-year-old? I mean, how do we want to? So typically, most people are going to. The young adult range is where we're looking at here, and the upper quartile of the reference range for the young adult male in this particular scenario, this is going to be 700 and this is going to be 900. So the upper quartile, the reference range for the young adult male is 900 to 1100. The young adult male doesn't have a lot of type 2 diabetes or prostate cancer or heart disease or Alzheimer's or erectile dysfunction, or the list goes on for every chronic disease that is impacted by androgens. So it would be really helpful if we had a reference range like this for women.
Yeah.
The reason that we don't is because the numbers are too small. Not only are the numbers too small, by the time women reach their mid-30s, the numbers are minuscule forever, all the way through menopause. I mean, it may be...
And that's normal.
It may be measurable.
Right.
But it's barely on the radar.
Right.
15, 10, 18, 20. Barely there. Now, that's helpful for women in menopause. It protects them from some chronic diseases, but it's not enough to make them feel like they did in college. So if you have a reference range and you mix all these women of all these different ages in here, you're going to get such a small number that you really can't use that reference range for therapy. Now, if someone were to give me a reference range of all women in their 20s, right, before they needed androgen therapy, then I might could use that reference range.
If they're not on birth control pills.
If they're not on birth control pills, which would blow it up. But this, you can't really use the reference range for women because you're looking at a range of all of women who needed to have their replacement and haven't had it.
Well, it's an interesting conversation because even with free testosterone, and this demonstrates your point beautifully, the lab that I use on women, the free testosterone, which is what's bioavailable, range is 0.0 to 4.5. So 0.0 for a free is expected.
Yeah.
But what we know normal, but what we know clinically is when women fall on this upper side of the bell curve, they feel better. Right. So it's the same conversation. So for men and women, you know, normal is not optimal. And what we also see that a lot of people, clinicians don't understand and don't discuss is for every 100 points a male testosterone falls below 900, his risk for certain diseases go up, and under 600, all-cause mortality goes up. So any and all cause of death can happen when a male testosterone is under 600, according to the clinical studies, but nobody knows this. And we're falling into this trap of this reference range.
So what do I see with the men in my office? Because we said what the women said. They said my thyroid's normal and my hormones are normal. Now what? Men, I see this over and over again. I've had my testosterone checked and it's
normal.
Low normal. That's what they're told.
Low normal.
Anything in the 300s, which is where everyone now over 45, over 40 or so, is in the 300s or 400s, and they're told it's low normal. Now, what they need to be told is there are plenty of studies that now show you are at risk for prostate cancer, type 2 diabetes, cardiovascular disease, Alzheimer's, and all-cause mortality when you're below 600. Yet, where in medicine do we have a lab test like free T3 or total testosterone in men that imparts a increased risk of all-cause mortality, and then we just don't treat it?
Let's create our own lab.
We don't even treat it.
Yeah.
I mean, how can you tell somebody they have a testosterone of 350, let's check it in a year?
Right.
That's like saying your hemoglobin A1C is 12. We'll check it again next year.
Yeah.
That doesn't make any sense.
You've got type 2 diabetes, but we'll just keep looking at it.
And the problem is testosterone's a scheduled medication.
Right.
It is confused with anabolic steroids. Most providers are not taught how to replace it during their training because of those two things, because it's scheduled. And all of this is just gets us where we are today, which is people not having their hormones replaced like they should, and all of this chronic disease that we have.
So let's talk in the last few minutes that we have about why we're seeing so much, because I'm seeing more and more young men in their 20s come down and that come to us below 300.
Yep.
Why is that happening? And then the same conversation for women, you're seeing more and more PCOS, infertility issues. And of course, that has a lot to do with thyroid and, you know, metabolic syndrome. But it's all disrupting this whole endocrine system. But let's talk about the guys, because we're seeing this more and more.
So we all know that men who exercise more make more testosterone.
Yeah.
Right? So if the testicle makes testosterone and it's sitting there in the testicle, and you go run 10 miles and pump all this blood past the testicle, pick up all the testosterone, your body's going to make more of it. Okay. And you're going to replenish it and make more of it, and you keep working out, you're going to be a healthier person, number one, but you're also going to have a higher testosterone level. So number one, we've got a lot of sedentary teenagers and people in their 20s. It's a sedentary lifestyle. Number two, it's the processed food. So it's the processed food, not just the processed stuff. It's the hormones in the food and the antibiotics in the food and the pesticides, and then all of these endocrine disruptors and all of the soy and all of these other things that are going to have some sort of negative feedback loop to your brain, telling you to turn off your production, because your brain is seeing all this other hormone-like stuff that you're getting. A chicken breast isn't supposed to weigh 4 pounds. Right? I mean, it's loaded with hormones, and you're eating those hormones, and your brain is saying, hey, we've got plenty of hormones. You should stop making as much, right? These are endocrine disruptors. It's actually a really good descriptive term for what this is. And I have a lot of kids that come in at college age, like you said, around 300 or even below, and they're sedentary and their diet is awful.
But they're ADD. Aren't they?
And now they have depression and ADD, and we have to treat with a bunch of prescription medicines instead of, you know what, it's time to research an organic diet, and it's time to get off the couch. And you need to get your supplements straight too, right? We need to make sure your B and D vitamins good and your probiotics are good, and you have good gut health. And we've got to change what you're eating, and we've got to change your activity level. If you don't make an effort to do it, if you're not making an effort to do it, you're getting poisoned.
Yeah, that's right. That's right. There's no doubt about it. And you're signing yourself up for a lifetime of medications, prescription medications. I see so many young 30-year-old males on blood pressure medicines and statins, for cholesterol. And we wonder why the age of dementia is getting younger and younger and younger, because we're starting people on these medications younger and younger.
And is heart disease getting less common now that we've been doling out these medications for 4 decades?
Hardly ever see it.
Yeah. Okay. It's not having the effect that they hoped that it would have. But there are side effects of all the prescription medicines that we use. And I hear that in my office from time to time. I really don't want to take pills. Well, I agree. And I don't like prescription medicines either, but I don't make the rules. Thyroid's a prescription medicine. Testosterone's a prescription medicine. Progesterone, estrogen. These are hormones. I look at these as natural hormones. Hormones and vitamins are all you're going to get in my office. But guess what? Some are prescriptions and some are pills.
Yeah.
And we're kind of stuck with that.
Wow. Well, a gynecologist that treats thyroid, talks about gut health, talks about diet, talks about organic food. You are pretty special. So I really thank you for coming on and having this conversation. We'll have more because there's a lot more to talk about with hormones. When you come into town, we'll get you back in here and talk some more. So thanks.
Fantastic. Thank you.